Welcome to the Deep Dive, the show that extracts the most important nuggets of knowledge and insight from complex topics, helping you stay well informed and right at the forefront of orthopedic understanding. Today, we're diving into a fascinating, yet often, let's be honest, perplexing orthopedic condition, neuropathic arthropathy, perhaps more commonly known as Charcot joint. Now, while it's frequently discussed in the context of the diabetic foot, we're really honing in today on an exceptionally rare and often puzzling presentation, Charcot of the elbow. Imagine a patient, let's call him John. He presents with a swollen, unstable elbow that, quite surprisingly, causes him very little pain. His elbow joint is, well, it's essentially self-destructing due to a profound loss of sensation. This makes it a really critical area for us as orthopedic professionals to truly understand. Joining me today to unpack this complex topic is the brilliant Prof. Mo Imam, whose extensive expertise will hopefully illuminate the nuances of diagnosis and management. We're going to delve into what causes this unusual condition, how it manifests clinically, and crucially, how we manage it effectively to preserve limb function. So, straight out the bat, what, in your view, is the single most immediate challenge that comes to mind when we talk about Charcot the elbow?
Well, the immediate challenge, and it's a significant one, I would say, is its exceptional rarity. It's just not seen very often at all. And this often leads to considerable delays in diagnosis, and sometimes, frankly, outright misdiagnosis. The typical presentation can be quite deceptive. It frequently mimics other far more common conditions, and that hallmark absence or a minimal reporting of pain, which, let's face it, we usually rely on as a primary patient complaint that can be a significant red herring. It really masks the severe underlying joint destruction that's going on. For someone like John, your hypothetical patient, his lack of pain is precisely what makes his condition so insidious.
Okay, so rarity and that deceptive lack of pain are the big hurdles. Let's unpack this for our listeners. Could you begin by defining neuropathic arthropathy? What exactly is happening within the joint and how did it acquire its well-known name?
Certainly. Neuropathic arthropathy, or Charcot joint as it's often called, is fundamentally a chronic, progressive, and highly destructive disease. It affects the bone structure and the joints themselves. At its core, it stems from a profound loss, or at least a significant decrease, in essential protective sensations. We're talking specifically about proprioception. That's our body's awareness of its position in space, along with pain and temperature sensation. Without these vital feedback mechanisms, the joint becomes extraordinarily vulnerable to damage. Think of it this way. Imagine a joint that simply cannot signal distress. It's continuously subjected to repetitive microtrauma from everyday activities, things that would normally cause a twinge, but here it goes entirely unnoticed. This leads to its eventual profound disorganization and destruction. That's why it's sometimes referred to, quite aptly, as a self-destructive joint.
A self-destructive joint. That's quite a stark image.
It is, and the condition is eponymously named after Jean-Martin Charcot. He was a pioneering French neurologist and professor of anatomical pathology back in the 19th century, often revered as the founder of modern neurology. In 1868, Charcot provided the first really comprehensive and detailed description of this condition. He observed grossly disorganized, often painless knee joints in patients who were suffering from tertiary syphilis, a condition he termed arthropathy of ataxic patients. Now, it's worth acknowledging that earlier descriptions did exist. John Mitchell Kearsley, for instance, back in 1831, described lower limb denervation leading to bone and joint destruction in, I think, 47 cases. And even further back, William Musgrave in 1703 documented what sounds very much like neuropathic arthritis. But it was really Charcot's meticulous clinical and histopathological descriptions that truly solidified his name in its nomenclature and brought the condition into clear medical focus.
Right, so his detailed work really defined it for the medical community. It's a condition where the very signals designed to protect our joints are absent, leading to this insidious and relentless damage. And Charcot himself, as you mentioned, a towering figure in neurology. He had quite a few other medical eponyms attached to his name beyond just this joint condition, didn't he? It really underscores the breadth of his contributions.
Indeed, his contributions were vast, absolutely. Beyond the joint condition we're discussing, Charcot's name is associated with a wide array of other medical conditions. It really highlights his profound impact on neurology and medicine as a whole. These include, for example, Charcot-Marie tooth disease, which is a group of hereditary sensory motor neuropathies. Then there's Charcot disease, another name for amyotrophic lateral sclerosis, or ALS, also Charcot-Wilbrand's syndrome, relating to visual agnosia, Charcot intermittent hepatic fever, Charcot's triad of acute cholangitis, Charcot-Gumbel necrosis, a form of biliary infarct, Charcot-Bouchard aneurysm, referring to small middle cerebral artery aneurysms, and even Charcot's triad of multiple sclerosis. It's quite a list.
It certainly is.
What unifies many of his observations, and is particularly pertinent to the joint condition, is the critical underlying role of peripheral sensory neuropathy. That's really the common thread, the key factor that connects many of these seemingly disparate clinical presentations he described.
Peripheral sensory neuropathy being the crucial link. Okay, so given this foundational understanding of what Charcot arthropathy is, how prevalent is it generally? And how does its incidence vary when we consider its manifestation in different anatomical locations? Is the elbow particularly susceptible, or are we dealing with something truly distinct here?
Globally, the prevalence of Charcot arthropathy varies considerably, and it primarily depends on the underlying cause, the etiology. In developed countries, with the, well, frankly, exponential increase in diabetes mellitus globally, diabetic peripheral sensory neuropathy, or DPSN as we often call it, has undeniably become the most common cause. There's no question about that. Studies estimate the worldwide prevalence of diabetes at around 8.3%, which affects approximately 387 million people. That's a huge number. DPSN, in turn, is estimated to affect somewhere between 14% and 63% of the diabetic population. That's a wide range, but it's a significant proportion.
A very wide range.
It is. And this translates to an estimated incidence of Charcot in diabetic patients ranging somewhere from 0.1% to 0.3%. However, and this is important for high-risk diabetic patients, perhaps those with poor glycemic control or longstanding disease, this figure can unfortunately soar to exceed 13%. And among patients already diagnosed with peripheral neuropathy, the overall prevalence of Charcot arthropathy increases to a significant 35%. So neuropathy is the big risk factor.
35%, that's quite striking.
It is. Patients with Charcot neuroarthropathy are usually in their 50s or 60s, and most have had diabetes for at least 10 years, which indicates it's usually a complication of long-standing disease. Interestingly, the risk of developing neuropathic arthropathy doesn't appear to be related to the type of diabetes per se, type 1 versus type 2, but it is observed perhaps slightly more commonly in individuals with type 1 diabetes, often presenting in their 5th decade, whereas for type 2, it typically presents a bit later, in the 6th decade.
Okay. And what about specific joint involvement? Does the location of the Charcot joint offer immediate clues about its underlying cause? Because that could be vital for a rapid diagnosis, couldn't it?
Absolutely. The pattern of joint involvement is actually quite distinct and provides invaluable diagnostic clues. It really points you in the right direction. For patients with diabetes, the foot and ankle, particularly the tarsometatarsal joints, the Lisfranc joint and the mid-tarsal joints, are overwhelmingly the most commonly affected sites. To give you some figures, studies show that roughly 50% of all Charcot cases occur in the midfoot, then about 28% in the hindfoot, 19% in the ankle, and only about 3% way down in the forefoot.
So predominantly foot and ankle in diabetes.
Exactly. If you see a Charcot joint, especially in a diabetic patient, your mind immediately goes to the foot. Conversely, for conditions like neurosyphilis, specifically tivus dorsalis, which affects the spinal cord, the hip and knee joints are more commonly involved, much bigger joints. And for cases of Hansen's disease, more commonly known as leprosy, the upper extremities are more frequently affected. So this geographical distribution within the body really points us towards the underlying neurological insult.
Which brings us directly to our primary focus today. What about the upper limbs, specifically the elbow? What does its involvement tell us, and why is this so particularly intriguing for clinicians?
This is where it gets really interesting and truly highlights the rarity we mentioned right at the outset. Neuropathic arthropathy of the elbow is an exceptionally rare condition. The medical literature reports only around 40 documented cases of elbow involvement, just 40, which represents a mere 3% to perhaps 8% of all neuropathic joints reported across the body.
3 to 8%, that's incredibly low.
It's tiny. This extreme rarity is precisely what makes our discussion today particularly pertinent for orthopedic professionals. It's a diagnosis you might genuinely encounter only a few times, if at all, in an entire career. And crucially, when we do see upper limb Charcot, especially affecting the shoulder or the elbow, syringomyelia is by far the most frequent underlying cause. It accounts for about 25% of all Charcot joints globally.
Syringomyelia.
Within syringomyelia cases, the shoulder is actually more commonly affected than the elbow, but elbow involvement, as in our hypothetical patient John's case, is certainly well documented, and it commands a very specific diagnostic pathway. It truly is a case of When you hear hoofbeats, think horses, but if you hear hoofbeats and it's the elbow acting strangely, you really have to consider a zebra, and that zebra is often syringomyelia.
So while it's rare, its presence in the elbow should immediately raise strong suspicion for specific underlying conditions like syringomyelia. It sounds like a critical diagnostic filter, a real red flag for the upper limb.
Exactly. It should trigger a specific thought process.
Okay, so we've defined what Charcot is, and we've established where and who it tends to affect, particularly its rare appearance in the elbow. But what's truly fascinating for us as clinicians is understanding how this destruction actually occurs. There are classical theories that have guided our understanding for decades, but also newer insights that paint a far more complete and perhaps more actionable picture, aren't there?
Yes, absolutely. The exact pathophysiology is still considered multifactorial, and it has indeed been a subject of considerable debate over the years. But two predominant theories have fundamentally shaped our understanding for decades. The first is the neurotraumatic theory. For many years, this was almost universally accepted as the primary mechanism. It posits that due to the profound loss of pain sensation and proprioception, that joint position sense we talked about, the affected joint, is continuously subjected to repetitive microtrauma. Think of it as constant minor insults, things like stress or fatigue fractures that in a healthy individual would normally cause pain and immediately prompt protective measures, like resting the limb or changing activity.
Right, you'd stop using it.
Precisely. Without that crucial pain signal, these insults go entirely unnoticed. The patient continues using the limb normally, maybe even excessively. This leads to progressive and severe joint damage. It's akin to continuously walking on a sprained ankle without feeling any discomfort, which would inevitably cause cumulative injury, malalignment, and abnormal loading, even with what we'd consider normal physiological loads of daily activities.
Okay, so mechanical damage from unnoticed trauma. What's the second theory?
The second, equally influential theory is the neurovascular theory. This theory suggests something slightly different. It suggests that autonomic neuropathy, which is a dysfunction of the involuntary nervous system, directly disrupts the sympathetic vascular supply to the affected limb. This disruption leads to hyperemia, or a significantly increased blood flow to the joint and surrounding bone. This hyperemia, in turn, is thought to cause increased osteoclast activity. Those are the cells that break down bone, leading to accelerated bone resorption. Essentially, the bone begins to dissolve itself. This process leads to fragmentation of the joint structures and ultimately severe joint destruction and deformity. This theory highlights the active biological, rather than purely mechanical, component of the disease. It suggests the body is actively breaking down its own bone due to this altered blood flow.
So traditionally, one theory focused on mechanical wear and tear due to the absence of sensation, and the other involved a biological process of bone breakdown due to altered blood flow. Is it one or the other, or has our understanding evolved into a more unified view now? This feels like where the crucial clinical insight often lies.
That's precisely where the critical insight lies. Current thinking, supported by a growing body of research, overwhelmingly suggests that Charcot arthropathy likely arises from a dynamic combination of both these mechanisms. It's no longer really seen as an either scenario.
A unified theory, then.
Yes, a sort of unified theory. The prevailing model suggests that a triggering traumatic event, and this can be incredibly minor, perhaps even imperceptible to a healthy individual, in the presence of that pre-existing neuropathy, initiates a robust inflammatory response. Now, this inflammation is not passive. It involves the widespread release of potent pro-inflammatory cytokines, things like interleukin-1 beta or IL-1 and tumor necrosis factor alpha, TNFS.
Right, the usual inflammatory system.
Exactly. These inflammatory mediators are known to stimulate something called ANKL, which stands for receptor activator of nuclear factor kappa B ligand. Bit of a mouthful.
It is.
But RANKL then directly induces the maturation and activation of osteoclasts, those bone-resorbing cells, leading to accelerated and profound bone loss. Now, in a healthy individual, this inflammatory cycle would typically result in significant pain. That pain prompts a protective splinting of the limb, rest, and allows for healing and repair. However, in our neuropathic patients like John, this crucial protective pain response is completely absent.
The alarm system is off.
Precisely. This absence allows for continued weight-bearing or use of the injured limb, which perpetually fuels the cycle of inflammation. This, in turn, cascades osteoclastic function, leading to relentless and eventual profound bone loss. It's truly a vicious cycle where the body's natural warning and repair systems are disarmed and completely overwhelmed. From a more molecular perspective, the rank-LBL-PRAG triad pathway, which is absolutely crucial in normal bone metabolism and remodeling, is indeed thought to be centrally involved in this unchecked destructive process.
So it's a dual-hit mechanical vulnerability plus an overactive inflammatory bone destruction process.
Exactly. This dual mechanism means we're not just dealing with passive damage from lack of sensation, but an aggressive biological assault on the joint itself.
That's a crucial distinction. It's not just the absence of pain allowing damage. It's an active destructive process that's unchecked, a fire that's allowed to rage because the alarm system is off. So what specific medical conditions predispose individuals to this unchecked destruction, particularly in the upper extremity, as we're seeing with Charcot of the elbow?
Well, beyond diabetes mellitus and neurosyphilis, specifically tabes dorsalis, which are historically the key causes everyone thinks of, Charcot arthropathy can arise from pretty much any condition that causes significant peripheral sensory neuropathy. The list is surprisingly long and diverse. For the upper extremity, and specifically the elbow, syringomyelia is, as we've established, by far the most common etiology. You absolutely have to rule that out.
Can you remind us what syringomyelia involves?
Yes, syringomyelia is characterized by the formation of a fluid-filled cavity, or a syrinx, within the spinal cord itself. It commonly occurs in the lower cervical and upper thoracic segments, right where the nerves to the arm originate. This syrinx directly damages the crossing fibers of the lateral spinothalamic tract. This leads to what we call dissociative anesthesia.
Dissociative anesthesia.
Yes, it means the patient loses pain and temperature sensation. But often, critically, they retain proprioception and motor function, at least initially. So they can still move the arm, they can feel where it is in space, but they won't feel pain from microtrauma or temperature changes that would normally signal damage or danger.
Which is incredibly dangerous for the joint.
Extremely dangerous. As the syrinx enlarges, it can further extend damage to the dorsal column, affecting proprioception more, and the anterior horn of the spinal cord, affecting motor neurons, resulting eventually in aphlexia, loss of motor strength, and muscle atrophy. A common underlying cause of syringomyelia, as we often see in clinical practice, is an Arnold-Chiari malformation, specifically type I.
Ah, yes, the cerebellar tonsil herniation.
Exactly. This involves the herniation of the inferior lobe of the cerebellum with elongated tonsils down into the spinal canal through the foramen magnum. Approximately 40% to 65% of Chiari type 1 malformation cases are in fact associated with spinal cord cavitation or syrinx formation.
So Chiari is a major cause of the syrinx.
It is. Other less common but important causes of neuropathic arthropathy, including those affecting the upper extremity, can include traumatic spinal cord injury, leprosy known as Hansen's disease, which is actually the second most common cause of upper extremity neuropathic arthropathy globally.
Leprosy, really? Still relevant globally, then?
Oh, yes, very much so in certain parts of the world. Also, genital pain insensitivity syndromes, chronic alcoholic intoxication leading to neuropathy, multiple sclerosis, HIV infection, severe vitamin B12 and folate deficiency, meningomyocele, and even poliomyelitis. There have even been rare cases implicating simultaneous kidney-pancreas transplant, highly active antiretroviral therapy, heart for HIV, osteomyelitis itself acting as a trigger, and even surgery causing nerve damage. So understanding these myriad underlying neurological conditions is absolutely paramount for accurate diagnosis and effective long-term treatment. Without addressing the root neurological problem, any orthopedic intervention is often just, well, patching a leak in a continually expanding dam.
Addressing the root cause is key. That makes perfect sense. That brings us to the front line. How does this devastating process actually manifest clinically, particularly when it affects the elbow? What are the telltale signs that orthopedic professionals should be actively looking for, especially given the deceptive nature of the condition and that typical absence of pain we've discussed?
Well, when a Charcot joint affects the elbow, the presentation, as you've rightly highlighted, can be quite deceptive. It often mimics an infection like septic arthritis or cellulitis because of its characteristic appearance. You'll typically observe a swollen, warm, and erythematous, meaning red joint. What's particularly striking, and often feels counterintuitive given the severe joint destruction that's happening underneath, is that roughly 50% of patients with elbow Charcot report minimal to no pain. Some may even present as entirely painless.
Half of them feel no pain. That's incredible.
It is. This painless destruction is a classic hallmark, and something you must always keep in the back of your mind when examining a warm, swollen joint, especially if there's underlying neuropathy. However, and this is crucial, it's important to remember that pain can be present in up to 75% of overall Charcot cases across all joints. It's just surprisingly less than one would logically expect for such significant damage. Therefore, the presence of pain for any clinician listening absolutely does not exclude a Charcot joint. You must remain suspicious even if there is some pain.
Right. Pain doesn't rule it out. Good point.
Beyond the visual cues, the swelling, warmth, redness, the loss of function is often the most common and significant complaint patients like John will actually report. They might say their elbow feels weak, unstable, or they just can't use it properly. On physical examination, in addition to those signs, you might also note gross instability of the elbow joint. It might feel strangely loose, almost floppy on examination. There will often be a distinct bony crepitus upon movement, that horrible grinding sensation of bone on bone or loose bone fragments moving around.
You can often feel that, can't you?
Oh yes, definitely. You might also encounter mechanical blocks to motion, limiting the range of movement, either flexion or extension. And a thorough neurological evaluation is absolutely essential. As I mentioned, ulnar nerve entrapment at the elbow is very common in these patients, simply due to the gross architectural distortion of the joint compressing the nerve. This can manifest as paresthesias in the ulnar nerve distribution, that tingling or numbness down into the little and ring fingers, interosseous muscle weakness, and visible muscle atrophy, particularly affecting the intrinsic muscles of the hand, like the interosseous and hypothenar muscles. In severe late cases, you might even see clawing of the hand.
So look closely at the hand as well.
Absolutely. You might also observe weakness in finger grip and sensory hypoesthesia, which is diminished sensation, over the dorsal aspect of the hand, particularly in the ulnar distribution. Patients might present acutely, perhaps following a seemingly minor trauma that tipped the joint over the edge. Or, because the pain is mild or absent, they may present at a much later stage with established gross deformities. We often see the classic rocker bottom foot in lower limb Charcot, frequently accompanied by plantar ulcers from abnormal pressure points. Unilateral presentation is more common than bilateral. And temperature changes between the affected and unaffected limbs can also be noted, particularly in the acute inflammatory phase. The Charcot elbow will feel noticeably warmer. And you can measure that difference. Yes, you can use skin thermometers. Neuropathy itself can be objectively assessed with the 5.0710 gram Semmes-Weinstein monofilament examination, which gives us a quantifiable measure of protective sensory loss.
So a swollen, warm elbow that's surprisingly not very painful, especially when accompanied by neurological signs down in the hand, should immediately raise a significant red flag for any orthopedic professional evaluating it. You've spoken about the 5Ds previously. Are these always present, or do they only appear at later stages of the disease?
Ah, yes, the 5Ds. They are indeed classic radiological and pathological features of advanced neuropathic arthropathy. Although clinicians often look for clinical correlates too. They stand for debris that scattered chunks of bone and cartilage floating around in fibrous tissue and within the joint cavity itself, increased density, specifically sclerosis or hardening of the bone ends as they try to heal and remodel under abnormal stress, destruction, the wearing away of the articular surfaces themselves, leading to loss of cartilage and underlying bone, disorganization, a profound alteration of the entire joint architecture, losing its normal anatomical shape and alignment. It just looks chaotic. And dislocation or subluxation, where the bones forming the joint are no longer properly aligned or articulating.
So those are signs of quite established disease.
Exactly. These are definitive signs of a profound, established disease process. However, this is where vigilance becomes absolutely paramount. In the earlier stage 0, Charcot, which was initially described by you, the acute findings might just be redness, warmth, swelling, and maybe bounding pulses. But critically, plain radiographs at this very early stage could still appear entirely normal.
Normal x-rays initially, that's worrying.
It is. Or they might show only very subtle, non-specific changes like slight joint space widening or perhaps simple, small, easily missed fractures. This stage 0 is easily missed if you're not acutely aware of the possibility of Charcot arthropathy. This really emphasizes the immense need for vigilance and maintaining a high index of suspicion, because early detection is absolutely critical if we want to prevent further irreversible bone and joint destruction. We often say the diagnosis of Charcot arthropathy is primarily a clinical one, meaning your suspicion based on the history and physical exam is your most powerful tool, often preceding definitive radiographic signs. You have to think of it.
Trust your clinical judgment, even if the initial x-ray looks okay.
Okay.
Given how varied the clinical presentation can be, especially with that deceptive potential for minimal pain, what are the main differential diagnoses that orthopedic professionals absolutely need to consider? And how do you navigate that often perplexing diagnostic challenge? This seems like the crux of the issue early on.
This is truly the most challenging aspect of diagnosing Charcot arthropathy, particularly in the acute phase where mistakes can happen. The primary and most critical differential diagnosis, without a doubt, is infection, specifically osteomyelitis, bone infection, septic arthritis, joint infection, or even surrounding cellulitis, skin infection.
Infection.
Absolutely. This is often the most difficult distinction to make, and there's a clinical adage that holds absolutely true, particularly for diabetic patients, but it applies elsewhere too. A swollen, red-hot foot in a diabetic is a Charcot joint or a deep foot infection until proved otherwise. The very same principle, though perhaps less commonly encountered, applies to the elbow. You have to rule out infection first. Both Charcot arthropathy and infection can present with a swollen, warm, red joint. And confusingly, both can lead to elevated inflammatory markers like erythrocyte sedimentation rate, or ESR, and C-reactive protein, or CRP. This makes laboratory differentiation incredibly challenging. Your patient, John, will likely present with these inflammatory markers elevated, but it won't definitively tell you whether it's Charcot or infection.
So the blood tests aren't specific enough on their own?
Not usually, no.
Mm.
Clinically, some subtle differences might offer clues, but they're not always reliable. For instance, the redness in a Charcot joint is usually more sharply demarcated and less rapidly advancing compared to cellulitis, where the edges might appear hazier or show more rapid spread. Crucially, if an open ulceration or break in the skin is not present and there's no history of traumatic inoculation, like a penetrating injury, a primary deep infection or cellulitis is statistically less likely, but it still absolutely requires exclusion. You cannot assume.
So how do you exclude it definitively?
The gold standard to rule out infection remains joint aspiration. You must try to obtain synovial fluid from the joint. That fluid needs to be sent urgently for gram stain, cell count with differential, and culture to identify any bacterial growth and guide potential antibiotic therapy. If you don't find bacteria, and the cell count isn't suggestive of sepsis, you become much more confident in a Charcot diagnosis.
Aspiration is key then. What else is on the differential list?
Beyond infection, other important differential diagnoses that must be considered include, firstly, severe trauma or fracture. A simple or even a comminuted fracture, especially in a patient with pre-existing neuropathy who might not have felt the injury properly, can certainly be an inciting event for Charcot, or it can simply mimic its early stages with swelling, pain, and deformity. So always get good quality radiographs.
Okay, trauma.
Secondly, deep venous thrombosis, or DVT. This usually presents with an enlarged, swollen limb, primarily in the lower extremities. However, upper extremity DVT can occur, particularly in patients who might be in a hypercoagulable state due to genetics, recent surgery at advanced age, prolonged immobilization, certain medications, or metastatic disease. Wells criteria and a duplex ultrasound are the standard tools for differentiation here.
DVT, right. Less common in the arm, but possible.
Thirdly, gout or other crystal-induced arthritis. Gout is caused by monosodium urate crystal deposition. It typically affects the first metatarsophalangeal joint in the foot, the big toe, but it can actually present in any joint, including the elbow. The key difference is that gout typically causes acute, excruciatingly severe pain, which stands in stark contrast to the relatively painless presentation of most Charcot joints. Elevated serum uric acid can be seen in gout, but it's not diagnostic on its own, and aspiration showing crystals is definitive.
The pain profile is usually very different then.
Usually, yes. Then you might consider something like an ankle sprain. If it were the lower limb, obviously less relevant for the elbow, but it's on the list for lower limb Charcot differentials. It usually has a clear history of trauma and tenderness in specific ligamentous areas. Radiographs rule out underlying fracture. And finally, although less common, you have to consider tumor. A primary bone tumor, or a metastasis, needs to be considered in atypical presentations, especially if there are other systemic symptoms like weight loss or unexplained bone lesions on imaging. A bone biopsy might be required in such ambiguous cases to rule out malignancy.
Okay, so it's clearly a constant and challenging balancing act between that acute clinical suspicion and the objective investigations. Considering that, how do imaging modalities really help us in this intricate diagnostic process, particularly in those ambiguous early stages where infection is the big worry?
Imaging is absolutely central. It's vital for confirming the diagnosis, assessing the extent of the damage in Charcot arthropathy, and perhaps even more importantly, for ruling out that critical differential of infection. It's essentially our window into the destructive process occurring within the joint.
So where do you start? Plain x-rays.
We typically start with plain radiographs, yes. Standard anteroposterior, or AP, and lateral views of the affected elbow are the essential first step. In early disease, as we discussed with stage 0, the changes might be subtle. They might initially mimic common osteoarthritis, perhaps showing some general degenerative changes, maybe slight joint space narrowing, and marginal osteophytes. However, as the disease progresses into the later stages, those 5Ds become strikingly evident on the X-ray. You'll see obliteration of the joint space, flattening of the articular margins, significant fragmentation of the articular surfaces, often leading to subluxation or even full dislocation, profound periarticular sclerosis, that dense white bone, and the distinctive presence of multiple loose bodies, often seen near the radial head in the elbow.
So X-rays are good for seeing the late-stage destruction.
Yes, and they also serve as a crucial baseline to monitor disease progression over time with serial imaging. We often use the Eichenholz classification system with its 3 radiographic stages: Stage 1, development fragmentation; Stage 2, coalescence healing; and Stage 3, reconstruction remodeling, to describe the severity and stage of the disease based on X-ray findings. And we add Stage 0 for those acute presentations without initial radiographic changes. For elbow Charcot specifically, getting cervical spine radiographs can also be valuable. They might screen for scoliosis or other spinal deformities which could hint towards an underlying neurological condition, like syringomyelia.
But X-rays, as you mentioned, with stage 0 aren't always enough, especially in those ambiguous early stages or when infection remains a strong possibility, correct? What's the next step in our imaging arsenal for someone like John where the X-ray might be inconclusive?
Precisely. This is where magnetic resonance imaging, or MRI, becomes absolutely invaluable. MRI is widely considered the test of choice for evaluating the complicated diabetic foot, and it is equally powerful, if not more so, for assessing the elbow in suspected Charcot. Its main advantage is that it can show Charcot arthropathy changes in much earlier stages than plain X-rays can pick up. It's much more sensitive to early changes.
What kind of changes does it show early on?
It can reveal subtle bone stress injury or microfractures, diffuse subcutaneous swelling and edema, significant marrow edema or enhancement in the subchondral bone areas, and periarticular soft tissue edema, all of which often precede visible fractures or fragmentation on an X-ray. It will also beautifully visualize joint distension by fluid and the presence of those multiple loose bodies, which can sometimes be difficult to fully appreciate on plain film, especially if they're cartilaginous. And crucially, for suspected elbow Charcot, an MRI of the cervical spine is absolutely indicated. You must order this to rule out a syrinx.
MRI of the spine, too, essential for the elbow.
Essential. As we've discussed, syringomyelia is the most common underlying neurological cause in this location. The MRI will clearly show the syrinx itself, often extending from C1 to C2 vertebra or further down into the cervical or even thoracic regions. And it can also confirm the presence of a related Chiari malformation with tonsillar herniation, which is frequently the underlying cause of the syringomyelia.
Okay, so MRI is great for early detection and finding the neurological cause. But what about differentiating Charcot from osteomyelitis? You said they can both look similar with bone edema.
That's the primary challenge with MRI, yes. Differentiating active Charcot from superimposed osteomyelitis can be tricky, as both conditions can show similar patterns of bone marrow edema and enhancement after contrast. Both light up brightly on T2-weighted or TR images. However, certain MRI patterns are more indicative of infection. Things like clear sinus tracts extending from the bone to the skin, well-defined subchondral cysts or fluid collections, diffuse bone marrow abnormalities that extend well beyond the joint margins, obvious cortical bone breaks, or localized rim-enhancing abscess formation.
Contrast helps them.
Adding gadolinium contrast can certainly help. It can further enhance the visualization of abscesses and inflammatory soft tissue changes like phlegmon, providing additional clues. It's also important for us, as clinicians interpreting the scan, to remember the clinical context. Osteomyelitis in the absence of an open ulceration or surrounding cellulitis is exceedingly rare in the upper limb, much rarer than in the diabetic foot. So that clinical information should strongly guide your interpretation of the MRI findings.
Right, context is key. Are there other scans that can help specifically with the infection versus Charcot dilemma?
Yes. To further aid this crucial differentiation, nuclear medicine bone scans can be employed, offering a different physiological perspective. A standard technetium 99-meter 3-phase bone scan will typically be hot or show increased uptake in both active Charcot joints and osteomyelitis due to the increased blood flow and bone turnover in both conditions. So it's sensitive, but not very specific for differentiation on its own.
So the standard bone scan isn't that helpful for telling them apart?
Not usually for telling them apart, no. However, an indium-111 labeled white blood cell, or WBC scan, is remarkably more specific for infection. The beauty of this scan is that the labeled white blood cells accumulate preferentially in areas of active infection where chemotaxis is occurring, but not significantly in areas of sterile inflammation or bone remodeling like you see in uncomplicated Charcot. So the WBC scan will typically be cold or negative in a neuropathic joint, but hot or positive in osteomyelitis. This makes it an incredibly useful tool for distinguishing between the two when clinical signs and standard imaging results are ambiguous.
So the WBC scan specifically looks for the white cells congregating. That makes sense.
Exactly. It targets the cellular response to infection. Finally, although it's rarely utilized in routine clinical practice, mainly due to its significant expense, we're talking somewhere in the range of 2,000 to 8,000 pounds here in the UK, and often limited availability, FDG positron emission tomography, or PET, scanning offers a distinct and potentially powerful advantage in very complex cases.
PET scans, how do they help?
PET differentiates infection from Charcot based on differences in glucose metabolism. Infected tissues, particularly the rapidly metabolizing bacterial cells and the highly activated inflammatory cells responding to them, result in a significantly higher uptake of the radioactive glucose tracer, FDG. This shows up as high standardized uptake values, or SUVs, typically ranging from 3 to 7, usually in a focal, distinct area corresponding to the infection. In contrast, Charcot, being primarily an inflammatory destructive process rather than an active bacterial infection, usually shows lower glucose uptake, with SUVs typically around 1.8 and often in a more diffuse, less focal pattern related to the joint destruction.
So it's about how metabolically active the area is.
Precisely. P scans are also particularly advantageous for patients who have metal implants from previous surgery, as they avoid the significant complicating image artifacts seen with MRI around metalwork. PD offers both high sensitivity and specificity in these challenging postoperative or implant-related cases. It's a powerful tool, albeit a resource-intensive one.
That's a comprehensive suite of imaging tools, each with its own strengths and weaknesses, truly highlighting the diagnostic challenges involved. So once a definitive diagnosis is established for Charcot's of the elbow, what's the recommended approach to management, particularly given its rarity and complexity? It's clearly not simply about fixing a broken bone here, is it? This requires a different mindset.
You've hit on a crucial point there. It's absolutely not just about fixing a broken bone. The entire approach has to be different. The overarching philosophy, or perhaps the motto, guiding the treatment of neuropathic joints in contemporary orthopedics has undergone quite a significant evolution over the years. It is now fundamentally about the maintenance of function of a joint rather than absolute immobilization.
Maintaining function, not just stopping movement.
Exactly. This represents a considerable shift from older paradigms where prolonged, rigid immobilization might have been the primary and often the only approach considered. The ultimate goal, whether it's the foot or, in our discussion today, the elbow, is to retain a stable, functional plantigrade for the foot, an ulcer-free joint. Or, if deformity has already begun, the goal is to prevent its further progression and stabilize what's there. Unfortunately, a single, clearly described treatment of choice for Charcot arthropathy itself remains somewhat elusive in the broader medical literature. There's no one-size-fits-all answer. This means management often needs to be highly individualized. It must be tailored based on the degree of functional limitation the patient is experiencing, the specific joint involved, the stage of the disease process, acute inflammatory versus chronic stable, and critically, the underlying neurological condition that caused it in the first place. It really requires patience and often a multidisciplinary team approach involving orthopedics, neurology, endocrinology, physiotherapy, and orthotics.
So it's about striking that delicate balance between protecting the joint from further destructive forces and allowing for useful movement and daily activities, a real tightrope walk for clinicians and patients. How does this philosophy translate into the initial, often conservative management approaches?
Conservative management is indeed the absolute first-line treatment approach for neuropathic elbow joints, and perhaps surprisingly to many, it has demonstrated reasonably promising results in some cases. Studies indicate that approximately 50% of patients report significant improvement following these non-operative interventions. Sometimes they even achieve remarkable maintenance of function despite what might appear as gross instability on their imaging. So for a patient like John presenting acutely, this would undoubtedly be our initial strategy.
Okay, so what does conservative care involve for the elbow specifically?
The cornerstone of conservative care involves several key components working together. Firstly, rest and activity restriction. Protecting the affected joint from further repetitive microtrauma is absolutely crucial, especially during the acute inflammatory phase. This means significantly reducing activities that put stress on the elbow lifting, pushing, pulling.
Activity modification is key.
Essential. Secondly, nonsteroidal anti-inflammatory drugs, NSAIDs. While pain is often minimal, NSAIDs are usually started to help manage any associated discomfort or, more importantly, the underlying inflammatory response. Even if the pain is mild, they can target that inflammatory cascade that contributes to the destruction. Thirdly, initial immobilization. This is a key initial step, particularly in the acute hot phase, to calm things down. For the elbow, an above-elbow slab or perhaps a long arm cast might be applied for an initial period, typically around 15 days, or until the acute swelling, warmth, and redness subside.
So short-term strict immobilization first.
Yes, initially. For Charcot in the foot, we use total contact casts or prefabricated devices like air casts, which are considered the gold standards for offloading the limb. The aim here is to minimize further bony fragmentation and allow soft tissue swelling to resolve. This requires serial X-rays and regular cast changes as the swelling reduces. This acute immobilization phase can be quite protracted, often lasting anywhere from 3 to 6 months, sometimes longer, until the joint cools down. And the total process of healing, or rather stabilization and remodeling, often takes 1 to 2 years. This is a long-term commitment for the patient.
1 to 2 years, that's significant.
It is. Fourthly, functional bracing. Once the acute swelling is reduced, the joint is less angry, and there is no further radiological evidence of bony fragmentation or ongoing destruction, the transition to a customized dynamic hinged elbow brace is often recommended. This type of brace allows controlled flexion and extension within a safe, preset range. It provides crucial stability to the unstable joint while still permitting essential mobility for daily activities. This allows the elbow to be mobilized safely within the brace, adhering to our maintenance of function motto.
So controlled movement replaces strict immobilization later on.
Precisely. Then, fifth, physiotherapy. Once the acute phase resolves and the joint is stabilized, either by remodeling or bracing, physiotherapy becomes absolutely essential. It's needed for regaining and maintaining range of motion, muscle strength around the joint, and overall functional independence. This needs to be a progressive program, very carefully tailored by an experienced therapist to avoid overstressing the vulnerable joint.
Gradual and careful physio.
Very. Sixth, management of patient expectations. Given the chronic and potentially progressive nature of the disease, it's vital to have frank and open discussions with the patient right from the start. They need to understand the anticipated course, the potential functional limitations, and critically, the lifelong need for vigilance and protection of the affected joint. They need to understand this is a marathon, not a sprint.
Setting realistic goals is important.
Hugely important. Seventh is patient education. Empowering the patient with knowledge about the specific risks of damaging an insensitive joint is fundamental. They need to understand the importance of daily limb checks looking for any new swelling, warmth, redness, or subtle changes in shape. They need to know to report any trauma, even minor bumps, or any changes immediately. They become an active partner in their own care.
They need to be their own joint monitor.
In essence, yes. And finally, eighth, and perhaps most importantly, treatment of the underlying disease. This cannot be overemphasized. For cases linked to syringomyelia, as in our specific case example with John, prompt neurosurgical consultation and appropriate management of the syrinx itself is critical. Decompression of the syrinx or the related Chiari malformation can slow the neurological disease progression and significantly improve the long-term orthopedic outcomes. Neglecting the neurological root cause is often a recipe for orthopedic failure down the line.
Treat the cause, not just the symptom. That's a really comprehensive approach to conservative care, focusing on protection, controlled function, and addressing the root problem. Are there any pharmacological interventions that effectively support this conservative management, or is it primarily mechanical protection and dealing with the underlying neurological cause?
Well, while the emphasis largely remains on mechanical protection and meticulously managing the underlying neurological cause, some pharmacological interventions have indeed been explored. However, it has to be said that the evidence base for their widespread application is still developing and somewhat controversial. There have been some smaller studies, mostly case series or small cohort studies, showing some modest benefit from using bisphosphonates. Drugs like palmidronate given intravenously or alendronate taken orally. These have been tried in the treatment of active Charcot joint, particularly if caught in the acute inflammatory hot phase.
And the rationale there is to reduce bone breakdown.
Exactly. The rationale is to reduce osteoclast activity and slow down that aggressive bone resorption that's part of the pathophysiology. However, it's important to note that a later, larger UK population-based study showed no such consistent benefit across the board with oral bisphosphonates. So the jury is still somewhat out on their routine use.
So maybe helpful in some, but not a guaranteed fix.
Precisely. Other agents like intranasal calcitonin spray, which also inhibits osteoclasts, or even potent anti-inflammatories like TNF-alpha inhibitors, drugs used for rheumatoid arthritis, have also been advocated by some authors. Again, the thinking is based on their ability to modulate that inflammatory cascade we discussed earlier, involving TNF-alpha and RANK-L. But for a clinician making decisions today, these treatments generally lack a robust evidence base from large, controlled, randomized trials for widespread recommendation outside of specific research protocols or very select cases. So while they're interesting avenues, they're not yet mainstream foundational treatments for Charcot arthropathy. Mechanical protection remains king.
Okay, so mostly mechanical and neurological management then. So conservative management is our first line, aiming to maintain function and prevent progression. But in a complex and destructive condition like Charcot, there must surely be a point when surgery becomes a necessary consideration, especially for a rare presentation like the elbow. When does that happen, and what are the available surgical options, bearing in mind the challenges?
Yes, surgical intervention is generally reserved for specific, more complex scenarios. It's certainly not the first option for most elbow Charcot cases. It's considered particularly when conservative measures have demonstrably failed to control the disease process, or when there's severe, debilitating joint instability that prevents basic function, or perhaps a persistent, unresolving infection superimposed on the Charcot joint, or simply an inability to effectively immobilize and offload the joint conservatively, maybe due to patient factors or deformity, or sometimes a non-healing ulcer related to the deformity.
So failed conservative care, severe instability or infection are the main triggers.
Broadly, yes. It's worth noting that for Charcot of the ankle joint, surgical intervention, often arthrodesis or fusion, is frequently recommended as the primary treatment. This is due to the typically poor outcomes often seen with conservative care alone in the ankle, given the high load-bearing nature of that joint and the difficulty in achieving stability. However, for the elbow, the situation is far more nuanced. Primarily due to its rarity, the different functional demands of the upper limb, non-weight bearing but requiring fine motor control and positioning, and the slightly better reported outcomes with conservative care compared to the ankle.
So a higher bar for surgery in the elbow, what's the first surgical consideration?
One absolutely critical surgical consideration, which sometimes gets overlooked by orthopedic teams focusing only on the joint, is directly addressing the underlying neurological cause, especially in upper limb Charcot. That means neurosurgical decompression. If a cervical syrinx or an Arnold-Chiari malformation causing it is present, as we strongly suspect in John's case with elbow Charcot, then neurosurgical decompression procedures are usually indicated.
Getting neurosurgeons involved early.
Essential. These procedures can include posterior fossa decompression, sometimes a craniotomy, placement of a syringoperitoneal shunt to drain the syrinx fluid, or a laminectomy to create more space. The aim is to reduce pressure on the spinal cord and ideally halt or shrink the syrinx. Neurosurgical decompression has been shown not only to potentially slow the neurological disease progression, but also, consequently, to maximize the potential for preserving orthopedic joint function, improve bone quality over time, and in some documented cases, even result in some remarkable elbow joint space restoration as the destructive process slows down.
Wow, treating the cause can actually allow some joint recovery.
In some rare cases, yes, if caught early enough. This is a vital first step because it addresses the root neurological problem, without which any purely orthopedic efforts are often fighting a losing battle.
Okay, so neurosurgery first if indicated. What about specific orthopedic surgical options for the elbow itself?
Other specific orthopedic surgical options, typically considered after appropriate neurosurgical intervention has occurred, if needed, or if neurosurgery isn't the primary issue, for example, diabetic neuropathy, include a few possibilities, mostly salvage procedures. One is peripheral nerve neurolysis. This might be considered for patients experiencing specific symptomatic nerve deficits, such as ulnar nerve palsies or perhaps posterior interosseous PIM palsies, which, as we mentioned, are common due to the joint's gross distortion compressing the nerves. Limited case series have shown reasonable recovery of nerve function with careful neurolysis, releasing the nerve from scar tissue or bony impingement. But it's important to counsel patients that high recurrence rates have been reported, presumably as the joint continues to remodel or deform over time.
So the nerve release might not be permanent.
It might not be. And performing something like a cubital tunnel release in this situation requires exceptionally careful soft tissue dissection, because the anatomy around the elbow is often severely altered and scarred. Then there's elbow arthrodesis, or fusion. This is essentially a salvage procedure. It's considered when patients experience intractable elbow pain, which can occur, remember, and severe functional instability, despite having failed a comprehensive trial of conservative management.
Fusing the elbow joint solid.
Exactly. While it obviously sacrifices all elbow motion, it has been shown to significantly improve pain control and provide a stable limb strut for functional activities like carrying or stabilizing objects. However, it comes with significant functional limitations as the joint is permanently fused. Patients find it hard to reach their head or perineum, for instance. It is rarely performed today, partly due to these functional limitations and partly because it's technically challenging. It's generally suggested only when no other reasonably reconstructive option is available and the patient understands and can adapt to living with a stiff elbow.
What makes it technically challenging?
Well, there are significant rotational and bending forces across the elbow joint, and achieving a solid fusion can be difficult, especially given the often poor bone quality associated with Charcot disease. Non-union rates can be high. The optimal position for fusion is also debated. Generally, around 90 to 110 degrees of flexion is considered optimal for most activities of daily living, allowing the hand to reach the mouth. But maybe 45-60 degrees of flexion might be better for specific work-related activities. It depends on the patient's needs and dominance. Contoured plate fixation, often using strong locking plates, is most commonly used to provide stability during healing.
And success depends on bone quality.
Yes, success factors can include younger patient age and, crucially, reasonable bone quality. One published case highlighted the innovative use of viable resected bone from the surgical site itself, the bone removed during joint preparation, being used as a local bone graft. This eliminated the need for a second surgical incision to harvest graft from the hip, for example, and its associated morbidity. That's quite a clever way to approach the bone stock issue sometimes.
That is clever. What about replacing the joint? Total elbow replacement.
Total joint replacement, or elbow arthroplasty. This is generally considered a relative and often absolute contraindication for an active or unstable Charcot joint.
A contraindication. Why is that?
The reasons are primarily the inherently poor bone stock associated with the disease. The bone is often sclerotic, but brittle, fragmented, and doesn't hold screws or cement well. This leads to alarmingly high risks of early prosthetic loosening, recurrent instability of the artificial joint, and significant issues with soft tissue compromise, wound healing problems, and often catastrophic deep infection around the implant. While very limited case reports exist, documenting attempts at elbow arthroplasties in patients with Charcot elbow, often after the Charcot process was thought to be quiescent, the results have been mixed at best and often tend towards poor long-term outcomes with high complication and revision rates. The underlying bone is simply not reliable enough to support the biomechanical demands placed on an artificial elbow joint long-term. It's usually best avoided.
So, surgery is mainly neurosurgical decompression or salvagation, with joint replacement being largely off the table. It sounds like surgical decisions are highly tailored, often addressing the neurological cause first, and then considering these salvage options only if conservative treatment utterly fails. Given these complexities, are there common complications associated with surgical interventions for Charcot joints that clinicians need to be acutely aware of even well after the operation?
Yes, absolutely. Surgical intervention, while sometimes necessary as a last resort, carries its own unique and significant set of risks, particularly in these highly compromised joints in patients. Postoperative complications are, unfortunately, relatively common. These can include the need for additional surgery due to ongoing instability, implant failure, or perhaps non-union in the case of an attempted arthrodesis. Persistent instability despite initial fixation is a real problem, and there's a significantly heightened risk of infection, especially if the underlying neurological condition isn't effectively managed, if the patient has other comorbidities like diabetes, or if there's any pre-existing skin breakdown or poor soft tissue coverage. For example, one documented case I recall involved an aseptic non-infected neuropathic elbow, managed initially with surgical debridement and external fixation for stability. Despite this, it still resulted in persistent instability, ultimately requiring further intervention. It just underscores the inherent challenge of achieving long-term stability in these cases. Furthermore, as with any major orthopedic surgery, particularly involving immobilization, upper extremity deep venous thrombosis, or DVT, is a potential risk that must be proactively managed with appropriate prophylaxis. These are absolutely not straightforward surgical cases by any stretch of the imagination. High risk, often with guarded outcomes.
High risk indeed. That leads us back to a recurring theme: infection. You've repeatedly mentioned infection as not only a critical differential diagnosis, but also a severe potential complication both before and after surgery. How does one truly manage a septic Charcot joint, especially given the inherent challenges of diagnosing infection in an insensitive limb where the usual red flags might be absent? This sounds like an orthopedic minefield.
It truly is a minefield, you're right. And managing infection superimposed on a neuropathic joint is indeed one of the most difficult and dangerous scenarios we face in orthopedics. The usual cardinal sign of pain, which normally alerts us forcefully to infection, is often absent or significantly diminished due to the underlying neuropathy. This means that a joint can become grossly infected, full of pus, with minimal or sometimes no patient-reported pain or tenderness. This often leads to a much later presentation when the infection is far more advanced.
So the patient might not even realize how bad it is.
It's exactly. Therefore, a systemic fever, or perhaps just unexplained elevated inflammatory markers on blood tests, might be the only clue alerting the physician to the possibility of underlying sepsis.
Yeah.
Even joint effusion, the accumulation of fluid in the joint space, which we normally look for, can be difficult to appreciate clinically in a severely distorted hypertrophic Charcot joint. It further obscures the diagnosis.
So if you suspect infection in a Charcot joint, what's the approach?
If infection is suspected in a neuropathic joint, swift and aggressive management is absolutely imperative. Any delay can be limb-threatening or even life-threatening if sepsis develops. The management typically involves a combination approach. Firstly, parenteral antibiotic therapy. Broad-spectrum intravenous antibiotics should be initiated immediately as soon as cultures have been obtained, ideally from aspiration or biopsy. They need to empirically cover both gram-positive and gram-negative organisms, given the potential for polymicrobial infection, especially if there's associated skin ulceration. These antibiotics are then tailored once definitive culture results, including gram stain and sensitivities, are available from the joint aspiration or surgical specimens. The most common organisms found in infected neuropathic joints are gram-positive cocci, particularly Staphylococcus species like Staph aureus. The duration of antibiotic therapy is often prolonged, typically requiring 6 weeks or more, often intravenously initially.
Long-term antibiotics are usually needed then.
Usually, yes. Secondly, surgical drainage and debridement. This is generally preferred as the initial method of drainage, especially if loculated pus is suspected or confirmed, over simply relying on repeated needle aspirations. Needle aspiration might not adequately drain thick pus or remove infected debris. Formal surgical drainage ensures thorough removal of purulent fluid, infected material, and allows for aggressive debridement of all necrotic bone and soft tissue. You have to remove all the dead tissue for the antibiotics to work and healing to occur. One case report highlighted that even after an initial surgical drainage, persistent serous discharge from the wound only resolved after an external fixator was applied to provide stable immobilization. This underscores the potential need for stability alongside infection control. Serial debridements may be necessary in some cases to ensure all non-viable tissue is removed.
So aggressive cleaning out of the joint surgically.
Aggressive cleaning, yes. And thirdly, appropriate immobilization. During the healing process, maintaining appropriate immobilization, perhaps with a cast, brace, or sometimes even an external fixator spanning the joint from the humeral shaft to the ulnar shaft, is necessary alongside the antibiotics and debridement. This immobilization helps prevent further mechanical breakdown of the infected joint, provides a stable environment for soft tissue healing, and supports the overall healing of the infectious process. Untreated or inadequately treated, a septic Charcot joint can rapidly deteriorate. It can lead to persistent osteomyelitis, even more severe deformity, chronic draining sinuses, and a markedly increased risk of requiring limb amputation, particularly in the lower extremity.
A very serious situation.
Extremely serious. The general principle is to act quickly and decisively whenever infection is suspected in a Charcot joint. Early diagnosis and aggressive combined medical and surgical management are imperative to avoid this rapid, potentially devastating progression. It's also worth mentioning the overall prognosis. Studies indicate that Charcot neuroarthropathy itself, even without infection, is associated with a higher mortality risk than diabetes alone, though perhaps somewhat lower than having an open diabetic foot ulcer. Reported 5 to 7 year mortality rates are somewhere between 15% and 24.5%.
That's quite a sobering statistic.
It is. It reflects the systemic nature of the underlying conditions and the severity of the complication. Prevention, therefore, is key. Particularly for Charcot related to diabetes, prevention focuses on meticulous control of existing diabetes through good glycemic management, regular foot screening in diabetes clinics to detect neuropathy early, and patient education about foot care. For conditions like syringomyelia, early neurosurgical consultation and intervention to decompress the syrinx is probably the best preventive strategy we have.
Prevention and early detection are critical then. What a truly insightful deep dive into neuropathic arthropathy of the elbow. It's abundantly clear that this rare condition presents a unique and formidable set of challenges for us, from that deceptive lack of pain which can mask severe destruction, to the complexities of distinguishing it from infection, and the nuanced, often highly individualized approach required for its management. It's certainly a condition that tests our diagnostic acumen and management skills.
Indeed. I think for our listeners, especially those dealing regularly with upper limb pathology, the key takeaways really boil down to the critical importance of maintaining a consistently high index of suspicion. You have to think about it to diagnose it. Always perform a thorough neurological evaluation, including sensation and motor function, when faced with an atypical or unusually swollen joint presentation, even if pain is minimal. And crucially, employ judicious use of advanced imaging, particularly MRI of the joint and the cervical spine for elbow cases, and perhaps WBC scans if infection is suspected to differentiate Charcot from its mimics, most importantly, osteomyelitis. Ultimately, whether the path forward involves neurosurgical intervention for underlying conditions like syringomyelia or meticulous long-term conservative management with bracing and therapy, or in select refractory cases considering salvage procedures like arthrodesis, the overarching aim remains consistent: to maintain as much joint function as possible and prevent those devastating limb-altering deformities. That guiding principle of preserving joint function over pursuing absolute immobilization, wherever feasible and safe, truly guides our modern approach. It's about ensuring the best possible functional outcome for the patient in the long run.
Absolutely. Early recognition, a high index of suspicion, and diligent, tailored, often multidisciplinary management are paramount to preserving the affected limb and maintaining a patient's quality of life when faced with this challenging condition. Thank you so much for sharing your invaluable insights and deep expertise with us today.
My pleasure. It's an important topic, despite its rarity.
And to you, our listeners, thank you for joining us on this deep dive. If you found this discussion insightful and valuable for your practice, please do take a moment to rate and share the deep dive. It really helps us reach more orthopedic professionals like yourselves. Until next time, keep learning, keep questioning, and keep critically thinking about those complex cases that come through your door. And remember that swollen, warm joint, particularly in the elbow or shoulder, presenting without significant pain, especially if there's a known history of neuropathy or an underlying neurological condition, should always trigger a comprehensive diagnostic workup for Charcot arthropathy. It's your earliest potential warning sign to intervene and hopefully avoid that downward spiral of fragmentation, fracture, and complete joint collapse.